go ahead and introduce our next speaker, Dr. Garret Wong, who's another one of my partner in the Division of Cardiology. Garret is the Associate Professor of Medicine with the Department of Cardiology, and he's going to talk to us about the same topic, except that it's antiplatelet therapy, which obviously there are more data.
Great. Well, thank you very much, Willie, for the kind introduction, and thanks, Dave, again, for introducing me to this great course here that every year seems to get bigger and better. Hopefully, Willie, we'll get you on the website. If not, my brother is a plastic surgeon at UC Davis, so we can certainly take care of you.
Yeah, I'll definitely make sure I have that appointment next week.
Absolutely. Let's see, how do we go advance here? Next slide. So without any further ado, I do have some verbal disclosures. I am on the Speakers Bureau for DSI Lilly and Bristol Myers Sanofi. So the outline for today, and I do apologize, the slides did not make the syllabus here, so these are available for downloading onto your USB drives before you leave the conference. So the outline for today, we're going to review the pathophysiology of platelet aggregation, review some of the oral antiplatelet therapies, and also briefly discuss some of the platelet function variability, which is getting a lot of press in the literature these days. So just briefly, the platelets, as you all know, they're a small anucleate blood cell. The primary function, as you know, is to maintain hemostasis. There are roughly 1.5 trillion platelets circulating in your system at any given time, and the lifespan is roughly 7 to 10 days, and it takes roughly a week to 10 days to repopulate your platelet population after they've been paralyzed by certain medications. They also secrete various clotting factors, vasoconstrictors, growth factors, etc. I always like to show this picture here because it's pretty amazing how they go from a small discoid shape, you can see in the bottom left there, to these spiny pedicles that kind of grow out when the platelets become activated, makes them very angry and sticky, and that therefore they clot together and close off these arteries and blood vessels and stents and whatnot. So what causes the platelet activation? As you can see, it's a very busy slide, and every year there's more updates to different things that lead to platelet activation. I'm not going to go through every one of these. A few to point out here are the ones that we're going to be talking about today, the ADP receptor blockers, which is working right up here right now, the P2Y12 specifically, and that's where some of the medications will block. Also the thromboxane pathway, as you all know, where aspirin works on that common pathway. And the final common pathway to clump or cross-link the platelets together is cross-linking the so-called GP2B3A, and it cross-links a molecule called fibrinogen to lead to the platelet aggregation. This is another schematic showing how when the platelet becomes activated by the various factors here, becomes very angry looking here, they clump together, cross-linking again the fibrinogen to lead to this big, huge platelet monomer. Concomitant to that, as you all know, the clotting cascade, all the different factors that we all know and love from hematology, leading to a thrombin and fibrin, which ultimately leads to a network of fibrin and thrombin, which lay a net over the so-called white clot to organize with red blood cells and whatnot in there to get the so-called red clot, or an occlusive thrombus. So the currently available antiplatelet therapies, obviously aspirin, dipridamol, which we're using in the combination form of aspirin and slow-release dipridamol in the form called Agrinox, and the thienopyridines, which all block the P2Y12 receptor of the ADP, clopidogrel, Ticlid, and also prasugrel. And cilostazol does have some antiplatelet benefits, and also the IV 2B3 inhibitors, which I'm not really going to discuss today, but you can see the three listed there. Just a little bit more focused detail, just the targeted therapies. We know that aspirin specifically blocks the cyclooxygenase pathway, which leads to production of thromboxane, therefore decreases or blocks this activation pathway. A different pathway is what these three medications, as well as ticagrelor, which is not yet approved, block the ADP receptor. So two different pathways which are summative rather than independently inhibiting the platelets. So we'll talk about aspirin first. Obviously, it's a very simple drug. It's the cheapest. It's been around for well over a century. One of the cheapest, most efficacious, cost-for-cost medications that we use. There's a plethora of data for this right now. This is from the ATC, the Antithrombotic Trial List Collaboration, a huge meta-analysis of multiple aspirin studies over the years. You can see here the different dosages that were used, the number of trials here. And again, if you're not used to looking at these whisker plot analyses, if it crosses the line of 1, that means statistically it's not significant. If it lands to one side, that medication or therapy is better. If it lands to the other side, that other medication or therapy is better. So these all line up very nicely to the left. So any dose greater than 75 milligrams shows significant benefit in decreasing cardiovascular complications. As you notice, the line here at 75 or less actually crosses the line of unity, did not reach statistical significance. So we recommend 75 or greater. We'll talk about Agrinox. As I mentioned before, this is a combination capsule. It's a slow release or depot release of the dipridamol. It's a BID, so twice a day medication as well as a low dose of aspirin. It inhibits the uptake of adenosine. So basically, it leads to an increased concentration of adenosine, which does have some platelet inhibition effects similar to prostacyclin. There's a chemical structure for the pharmacologists in the room. There's a lot of data on this. One of the biggest trials that came about was the ESPRIT trial. There's also a corollary trial, the ESPS, the European Stroke Prevention Trial, which the data looks almost identical here. This looks at many thousand patients, average follow-up, comparing. The top line, the yellow, is the aspirin versus the Agrinox combination here. And this doesn't show the numbers, but there's a roughly 20% decrease in complications and recurrent stroke, essentially. The other trial, the PROFESS, this is the largest secondary stroke prevention trial to date. Over 20,000 patients enrolled. You can see the map of the many different countries enrolled in this trial here. And this was a comparison of Agrinox to clopidogrel. What did they find in this trial? They found that essentially there's no clinical difference between clopidogrel and the Agrinox. The lines are essentially superimposable. This was published in the New England Journal in 2008. And we'll talk about clopidogrel now. So as you may or may not know, clopidogrel is a prodrug, meaning it has to become activated by going through the liver, as many of our drugs do. It requires the cytochrome P450 system, which metabolizes many of the different drugs that we use. And it requires a two-step process to go through the liver. As you know, if you gave a single dose once a day, it would take upwards of 5 days to become therapeutic at your steady state. 300 milligram loading doses, which have been studied in numerous trials, particularly in the coronary arena, takes anywhere from 4 to 6 hours, and 600 milligrams, which is essentially a standard of care now, certainly in the cath lab. If they've not been on therapy prior to the procedure, they get 600 milligrams as you achieve a steady state much quicker. There are some different resistance mechanisms, which I'll talk about a little bit later, as well as leading to variability in individual response. And all in all, you get roughly 40% platelet inhibition. It's a very effective drug, but still 60% of your platelets are still functional at that point in time. Here again is another slide for the pharmacologist in the room here, showing the metabolism. Again, it takes a two-step process to become converted to the active metabolite, which binds irreversibly to the P2Y12 receptor. Some of the early data was the CAPRI trial. This is the landmark trial looking at almost 20,000 people comparing aspirin to clopidogrel, not combination therapy, aspirin to clopidogrel in people with known vascular disease, so cerebral vascular disease, carotid disease, coronary disease, or peripheral arterial disease, and compared them in 1-to-1. And you can see here at 3 years of follow-up, there's a significant reduction, 8% relative risk reduction compared to aspirin. It did achieve statistical significance. How about combination therapy? Well, the CURE trial, this is actually an acute coronary syndrome trial from in the cath lab, but this is comparing aspirin plus placebo versus aspirin plus clopidogrel. So combination therapy, not one versus the other. This is combination therapy, and achieved, as you can see here, very highly statistical significance at 1 year, very strong p-value, 20% relative risk reduction compared to aspirin alone. So certainly for acute coronary syndrome, your coronary patients, ACS, certainly combination therapy is the way to go. How about the Charisma trial? This is a different population. It wasn't the ACS population. Again, it's a high-risk population, very similar to the CAPRI trial, in that the patients with known CAD, CVD, or PAD, and roughly 12,000 in that group, did have a significant reduction, again, combination therapy. So aspirin versus combination of aspirin and clopidogrel, and it did achieve statistical significance. However, if you just teased out the people just with the risk factors but did not have known disease, they did not show the same benefit. So combination therapy is really restricted to people who have known documented disease. So here's a picture of a carotid stent thrombosis, which unfortunately we don't like to see. Fortunately, it is a quite rare event. You can see the numbers there are much less than 1%. Very less frequent than we see in the coronary. In coronaries, it's anywhere from 1.6 to 1% per year. It's usually described within the first 30 days, so certainly dual antiplatelet therapy in the carotid stenting arena is quite essential. This is a trial shown several years ago now you can see here the European Journal of Vascular Surgery comparing aspirin plus heparin versus dual antiplatelet therapy. And we learned this early on in the coronary world that dual antiplatelet therapy is much more important rather than antithrombotic, Coumadin therapies, et cetera, for decreasing stent thrombosis. You can see here in the aspirin alone arm with the anticoagulation versus dual antiplatelet therapy, quite a significant difference. So dual antiplatelet therapy is key for carotid stenting. Here's a slide just showing the differences in response to clopidogrel. And you can see here, this is the two curves that basically show the level of platelet inhibition, the level of platelet inhibition here. And clopidogrel at 300 milligrams on this curve versus 600 milligrams. And again, the 600 achieves a higher peak and a quicker onset. But as you do notice, this is a bell-shaped curve. Not everybody gets the same exact response. And there are some hypo responders and there are hyper responders. And there's many causes. I'm not going to go through all of these here, but this will be in your downloadable presentation. You can look at these. But there's a lot of work on the different genetic receptor polymorphisms, specifically the P2Y12, the P2 receptor, and also the 2C19, which you'll see interacts with quite a few medications, including the PPIs. So certainly genetic variability in the patients themselves. Non-compliance is by far the biggest risk factor for stent thrombosis. Drug-drug interactions, as I mentioned, the PPIs are getting a lot of press. And certainly just the patients themselves, diabetics, people with known disease, and also I should have added here, chronic kidney disease. We do know that those people do have decreased response to clopidogrel. Here's just one trial from the American Journal of Neuroradiology looking at clinical outcomes in supra-aortic stenting. What this is here, they took 50 people and they analyzed their blood. This is a different assay looking at the platelet aggregation, so that you put their blood in a sample and it finds out how much of the platelets are still clumping. So the higher the number it is, the more the platelets are still functional and potentially able to clot. So you want a nice low number here. So if you see here is clearly this group of patients up here, and it turned out to be 14 of the 50. So 28% of the people turned out to be, quote, non-responders, meaning they didn't get the appropriate response after getting the load of the clopidogrel. And you can see the majority of those people, majority of the 14, were loaded with less than 12 hours. One of these people, patient number 2, as you can see right here, actually developed a peri-procedural in-stent thrombosis. You can see here a lot of platelets are so clumping, so they actually use a 2B3A inhibitor, tyrofabin, to reverse the antiplatelet benefits, or to reverse the platelet aggregation inside the cath lab. So it certainly does have some clinical significance. It can be very acute as well. There's a lot of data on dual antiplatelet therapy and stent thrombosis and whatnot, and resistance levels on coronary work. What about the carotid? Is the carotid the same arena? Well, clearly it's not. You can see the size differences. Anywhere from 7 to 8 millimeters is pretty standard for the internal carotid artery. A large vessel for us is 3.5 millimeters. You get these 2.5 millimeter, 2.25 millimeter vessels, and there's a much higher likelihood of stent thrombosis. So the data doesn't quite correlate and translate. As you can see, the numbers for coronary or carotid stent thrombosis is quite low. Allergy issues, this is an important topic that always comes up. So aspirin and clopidogrel allergies, these need to be discussed with the patient before you get them in the table, before you're deciding your therapy. If you're going to put them on long-term dual antiplatelet therapy, if you know that they're allergic, that becomes quite important. There are protocols for desensitizing people with both aspirin and also clopidogrel as well. They do need to be done in a monitored setting with your allergy colleagues to assist with that. Now, there are newer drugs that can be used as well if someone does have an allergy. Tyclid is old standby, cilostazol, prasugrel, as well as ticagrelor, which may be coming out soon. So, is aspirin, Plavix, and Agronox enough for everybody? Do we have a need for newer agents? Well, certainly there are newer agents that I alluded to. I'm not going to spend too much time on these, but just to briefly give you some information about what's coming on the horizon. There's no real data in the peripheral arterial world or carotid world yet, but potentially those trials may be coming. Prasugrel, as you can see here, it's a prodrug similar to clopidogrel. It requires only a single-step process through the liver, so it's a little bit easier conversion, so you achieve a higher level of platelet inhibition. You get roughly 80%. So roughly double you get with clopidogrel. This just shows the two mechanisms here, relying, again, on a one-step mechanism and a two-step for clopidogrel versus a single-step for prasugrel. This just outlines that the 2C19, which again, you see this quite a bit in the literature right now, a lot of genetic variability in the 2C19. You could actually send your blood samples out. They're commercially available to check if your patient has one of these genetic defects. And it inhibits the enzymes here. So if a patient has a particular deficiency in this enzyme, they don't convert to the active metabolite, and therefore they don't even achieve the 40% platelet inhibition. Well, prasugrel, on the other hand, still requires activation or to the active metabolite, but uses multiple pathways, so it doesn't rely as heavily on the 2C19, so they aren't as inhibited by the genetic variability. This is just one slide showing you the differences in platelet inhibition. This is kind of the opposite of what I showed you before. This shows the levels of the platelets are blocked. So on this one, the higher the level it is, the better. So prasugrel, as you can see, receives roughly a doubling of the platelet inhibition. Here's the landmark trial. This, again, is a coronary trial for ACS in the setting of PCI. So it's a limited indication right now. It's not available for PAD or carotid work, but it is available for the coronaries. And you can see here comparing, now this is aspirin plus clopidogrel versus aspirin plus prasugrel. And again, this is their cumulative events, standard endpoints, heart attack, death, and stroke. And they found a significant decrease of prasugrel compared to clopidogrel, again, in the ACS population, acute coronary syndrome population. What's the downside? It's more potent. It led to more increased risk of bleeding here. So that leads to the greater inhibition. Is it better? Well, on one hand, you have less bleeding. This is roughly where clopidogrel is at 40% platelet inhibition, but they do have some increased events, as opposed to prasugrel, which gives you roughly 70%, incidentally ticagrelor, which will be approved, gives you roughly 70% platelet inhibition as well, but does that translate into more bleeding? So again, it has to be weighed, the risks and benefits per the patient population that you're working with. Ticagrelor, I'm not going to mention anything other than that it's filed with the FDA, so it should be potentially getting approved very soon. Platelet function testing, this is something that's come really into play in a lot of the work that we're doing right now, specifically in the coronary arena, again, there's a much higher incidence of stent thrombosis in the coronaries compared to the carotid world. But there's numerous platelet function studies right now. Here's just a listing of many that are out there. I'm not going to go through each of these. Suffice to say that it's a marked advance from the old times when we were doing bleeding tests, where you sit there and poke the patient and wait till they clot and count how long it took. Newer devices here, getting a little more sophisticated. And now we're getting to the point where we have point-of-care testing, and this is what we use in clinical trials and whatnot, and this, again, commercially available. You basically take a little sample of their blood, put it in here. This could be done at the bedside, just like running an ACT, and you know within 5 minutes, are they still platelets are clumping, or are they relatively inhibited? So it's a very useful test. You could specifically look at aspirin effects. There's a cartridge specifically looking at the P2I12, so specifically the effects of Plavix or prasugrel. There's also one specifically looking at the effects of a 2B3 inhibitor. So it's very useful information if you have a patient who potentially thromboses and they're taking their medications. Certainly point-of-care testing would be very useful. Lastly, here's a slide on the guidelines. I'm not going to read through this, but it just says aspirin, pretty much used for everybody. If they can't take that, clopidogrel is a great option. They do not recommend the combination therapy, and there are certainly studies looking at anticoagulation with Coumadin is not recommended right now for the reduction of ischemic events, certainly not in combination with aspirin at this point in time, unless there's a concomitant need to be on the Coumadin. And finally, the take-home points. So aspirin, it is safe and effective essentially for all cardiovascular patients unless there's a clear contraindication. Agrinox, the benefit is mainly seen in the stent stroke patients, And the safety of clopidogrel, it's been around for many, many years, and this safety has been confirmed in a broad spectrum of patients, particularly the coronary world, carotid disease, peripheral vascular disease. So certainly it's a tried and true medication. There are new drugs on the horizon to be on the lookout for. Again, the data is not there yet for prasugrel, ticagrelor in the endovascular world, but we may see that down the road. And certainly genetic and platelet function testing, that could be literally a whole entire topic, but I just wanted to give you a flavor of what's commercially available. And with that, I'd like to end it, and happy to answer any questions. Thank you.
Thank you, Gary.
Bigger and better. Hopefully, Willie will get you on the website. If not, my brother is a plastic surgeon at UC Davis, so we can certainly take care of you.
Yeah, I'll definitely make sure I have that appointment next week.
Absolutely. Let's see, how do we go advance here? Next slide. So without any further ado, I do have some verbal disclosures. I am on the Speakers Bureau for DSI Lilly and Bristol Myers Sanofi. So the outline for today, and I do apologize, the slides did not make the syllabus here, so these are available for downloading onto your USB drives before you leave the conference. So the outline for today, we're going to review the pathophysiology of platelet aggregation, review some of the oral antiplatelet therapies, and also briefly discuss some of platelet function variability, which is getting a lot of press in the literature these days. So just briefly, the platelets, as you all know, they're a small anucleate blood cell. The primary function, as you know, is to maintain hemostasis. There are roughly 1.5 trillion platelets circulating in your system at any given time, and the lifespan is roughly 7 to 10 days, and it takes roughly a week to 10 days to repopulate your platelet population after they've been paralyzed by certain medications. They also secrete various clotting factors, vasoconstrictors, growth factors, etc. I always like to show this picture here because it's pretty amazing how they go from a small discoid shape, you can see in the bottom left there, to these spiny pedicles that kind of grow out when the platelets become activated, makes them very angry and sticky, and that therefore they clot together and close off these arteries and blood vessels and stents and whatnot. So what causes the platelet activation? As you can see, it's a very busy slide, and every year there's more updates to different things.
Go ahead and introduce our next speaker, Dr. Garret Wong, who's another one of my partner in the Division of Cardiology. Garret is the Associate Professor of Medicine with the Department of Cardiology, and he's going to talk to us about the same topic, except that it's antiplatelet therapy, which obviously there are more data.
Great. Well, thank you very much, Willie, for the kind introduction, and thanks, Dave, again, for introducing me to this great course here that every year seems to get a lead to platelet activation. I'm not going to go through every one of these. A few to point out here are the ones that we're going to be talking about today, the ADP receptor blockers, which is working up here right now, the P2Y12 specifically, and that's where some of the medications will block. Also the thromboxane pathway, as you all know, where aspirin works on that common pathway. And the final common pathway to clump or cross-link the platelets together is cross-linking the so-called GP2B3A, and it cross-links a molecule called fibrinogen to lead to the platelet aggregation. This is another schematic showing how when the platelet becomes activated by the various factors here, becomes very angry looking here, they clump together, cross-linking again the fibrinogen to lead to this big, huge platelet monomer. Concomitant to that, as you all know, the clotting cascade, all the different factors that we all know and love from hematology, leading to a thrombin and fibrin, which ultimately leads to a network of fibrin and thrombin, which lay a net over the so-called white clot to organize with red blood cells and whatnot in there to get the so-called red clot, or an occlusive thrombus. So the currently available antiplatelet therapies, obviously aspirin, dipridamol, which we're using in the combination form of aspirin and slow-release dipridamol in the form called Agrinox, and the thienopyridines, which all block the P2Y12 receptor of the ADP, clopidogrel, Ticlid, and also prasugrel. And cilostazol does have some antiplatelet benefits, and also the IV 2B3 inhibitors, which I'm not really going to discuss today, but you can